Welcome to our channel Medicine A to Z. Today, we are talking about G6PD deficiency. If you gain anything from this video, please click the like button to support us. Etiology. G6PD deficiency, glucose 6-phosphate dehydrogenase, is caused by mutation of gene in X chromosome. We're diving into the genetics of G6PD deficiency. Inheritance and impact on males. Males with a G6PD mutation are hemizygous, meaning they have only one X chromosome with the mutation. This mutation affects all red blood cells, RBCs, in these males, leading to a higher risk of hemolytic anemia. Inheritance and impact on females. Females with a heterozygous G6PD mutation typically do not show severe hemolytic anemia. Why? Because approximately half of their RBCs express the normal G6PD allele, while the other half express the abnormal allele. Most females with a G6PD mutation are simply carriers and do not exhibit symptoms. However, there's a twist. If the normal allele is inactivated in a process called lyonization, a female carrier can experience severe anemia. Epidemiology. G6PD deficiency affects 400 to 500 million people worldwide. Geographic distribution. This condition is most prevalent in the tropical and subtropical zones of the Eastern Hemisphere, including Africa, Europe, the Middle East, Asia. Correlation with malaria. There's a strong correlation between G6PD deficiency and regions where malaria was once endemic. It's hypothesized that G6PD deficiency may have provided a selective advantage against malaria infection by Plasmodium falciparum. NADPH is produced by the G6PD enzyme. Its job is to convert oxidized glutathione into reduced glutathione. Why is this important? Because reduced glutathione is like a superhero that fights off free radicals and oxidants, protecting our cells from oxidative stress. So, without enough NADPH, our cells can't get enough reduced glutathione, making them vulnerable to damage. In short, NADPH, produced by the G6PD enzyme, is essential for keeping our cells safe from oxidative stress by ensuring a steady supply of reduced glutathione. In G6PD deficiency, the level of NADPH remains low. This low NADPH leads to reduced levels of glutathione, our crucial defender against free radicals. Without enough reduced glutathione, free radicals increase, causing damage to red blood cells. This damage triggers hemolysis, where red blood cells break down both inside blood vessels, intravascular, and outside them, extravascular. If someone with G6PD deficiency ingests food, drugs, or chemicals rich in oxidants, it can rapidly accelerate this hemolysis, leading to significant problems. Classification. Let's briefly discuss the classification of G6PD deficiency. Class 1, severe enzyme deficiency, with less than 10% of normal activity, leading to chronic hemolytic anemia. Class 2, also severe, with less than 10% of normal activity, but causing intermittent hemolysis. An example is the G6PD Mediterranean variant. Class 3, moderate enzyme deficiency, with 10 to 60% of normal activity, leading to intermittent hemolysis. This is common in individuals of African ancestry. Class 4, no enzyme deficiency and no hemolysis. Class 5, increased enzyme activity and no hemolysis. Let's talk about the clinical manifestations of G6PD deficiency. Asymptomatic. Most individuals, including those with common variants like Mediterranean and African G6PDA, show no hemolysis or anemia at steady state. Chronic hemolytic variant. This is very rare and falls under Class 1. Neonatal jaundice. Some newborns with G6PD deficiency may develop jaundice. Typical presentation. Sudden onset of jaundice, pallor, and dark urine, with an abrupt fall in the hemoglobin concentration by 3 to 4 gram per deciliter after 3-4 days of drugs or food ingestion. There may be abdominal pain and/or back pain. Some may develop mild self-limiting hemolysis, whereas some develop severe life-threatening hemolysis. Let's quickly go over some triggering agents for G6PD deficiency. Medications to avoid include chlorpropamide, dabrafenib, dapsone, diaminodiphenyl sulfone, fluoroquinolones like ciprofloxacin, moxifloxacin, norfloxacin, and ofloxacin, methylene blue, methylthioninium chloride, nalidixic acid, nitrofurantoin, nifuratel, and nitrofurazone, nitrofural, phenazopyridine, pyridium, primaquine and tafenoquine, rasburicase and pegloticase, sulfonylureas like glipizide and glyburide, glibenclamide. Avoiding these can help prevent hemolysis in individuals with G6PD deficiency. Chemical exposures and foods to avoid include fava beans, henna compounds, black and red Egyptian, naphthalene, found in mothballs and lavatory deodorants, phenylhydrazine rush, isobutyl nitrite, amyl nitrite. Additionally, infections are the most common illness that causes hemolysis in G6PD deficient individuals. Let's talk about what you can see in a peripheral blood smear for G6PD deficiency. You might see microspherocytes eccentrocytes, also known as bite cells, blister cells. Special stains can show the presence of Heinz bodies. Hemolysis occurs both extravascularly and intravascularly. Diagnosis: screening tests by assessing the normal function of the G6PD enzyme, reduction of NADP to NADPH, determined by monitoring a fluorescent spot under ultraviolet light. Confirmatory tests: the quantitative tests assay NADPH formation quantitatively. Management of acute hemolytic episodes: remove the cause, identify and eliminate what's triggering the problem. Stay hydrated. Drink plenty of fluids. Consider a blood transfusion, if needed, to replace lost blood. Avoid unsafe drugs and chemicals. Dietary restrictions: avoid fava beans, broad beans. They can trigger anemia in people with G6PD deficiency. Sensitivity varies among individuals.
Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.